We'll be back.
All right, so should I go ahead and get started?
Hirsch, give us 1 sec. Steph is gonna
All right.
step right in. And a couple more people might still trickle in. Um, but how has the year been for y'all?
It's been great. I think residency's been great. We're having a good time. Life's good.
You're enjoying Denver?
Yeah, yeah, no, Denver's great, and I'm happy to be presenting a case for the first time. Maddie's been bugging me to do this for years now. Um, and so yeah, excited to be here.
Very cool. Is this a patient you saw in the wards or clinic or?
Yeah, yeah. So this is a patient I saw at the VA about a week ago.
Hmm.
Um, actually on we admitted him on Christmas Eve. So, but yeah.
It's a time of year with a lot of uh, mixed emotions for us working in hospitals. And yeah, hard being admitted to the hospital over the holidays.
Yeah, I mean, this patient, he was an absolute joy to hang out with. So, as far as, he was a pleasure to admit.
Very cool. And I'm hoping to that the kids will allow us to stick around. Um, and Steph is saying to go ahead and get started. So let's do that, and we'll pause and I'll catch her up whenever she's able to join. Sorry about the hectic start, but excited to hear about your patient, Hirsch. Please go ahead.
All right. So, I'll go ahead and start with the first aliquot. So, on Christmas Eve, we got a call from the ED about a 79-year-old male, so pretty standard for the VA, who came in with 1 month of feeling like he couldn't take a full deep breath. And then part of the sign out we got was that he was persistently tachycardic to the 120s while at rest. And I'll go ahead and stop there, and would love to hear your thoughts.
Thanks, Hirsch. And and by the way, everybody, please, as always, feel free to unmute and raise your hand or jump in and share any and all thoughts. So Steph, Hirsch just told us that he admitted a gentleman on Christmas Eve who was 79 and who had come in with a feeling of not being able to take a full breath or deep breath, but was also tachycardic to the 120s, and that's all we know so far. Um, so I'll just share my first reaction, which is funny to start with a diagnosis of exclusion. But I will, and then I'll tell you why it's not the case, very probably. Um, the diagnosis of exclusion in question is anxiety as a cause of dyspnea. Um, and I think hopefully it's obvious why it should be a diagnosis of exclusion. As an old pulm crit attending of mine used to say, when that possibility was invoked, he liked to say, "Is the patient dyspneic because they're anxious, or are they anxious because their doctor can't figure out why they're dyspneic?" And of course, uh, you certainly don't want to jump to that conclusion and miss any one of the panoply of life-threatening causes of dyspnea. And of course, it's anxiogenic to feel like you can't breathe. So I'm sure that's intuitive to all of you. But the reason why that came to mind first is actually that two features of dyspnea from anxiety that I've kind of repeatedly noticed, um, both in myself and my friends and family and in patients. One is that people often describe it as this feeling of needing to take a deep, satisfying breath, something called a sigh breath that we all take multiple times a day, and not being able to do so. But then, once in a while, in fact, frequently, then being able to take that deep, satisfying breath and then achieving relief from that feeling of dyspnea, only for it to come back within a few minutes, and again feeling like you can't take this deep enough, satisfying enough breath. So that's one feature, that very specific kind of descriptor, and the other is dyspnea that actually improves with exertion as opposed to worsening with exertion. Sort of being distracted by your body moving, being distracted from your thoughts by movement can also help alleviate that anxiety and that sort of dyspneic feeling related to anxiety. And the dagger in the heart of that being the diagnosis is both the fact that, again, you haven't excluded everything you need to, but also the sustained tachycardia, which while, anxiety, panic attacks acutely can cause, again, it's just another sort of a second thing that is an absolute diagnosis of exclusion that we haven't at all done the work to exclude. So those are my sort of just snap thoughts, and wanted to use that opportunity to share my experience with that diagnosis of exclusion. But now going back to the work we need to do is to think about, I saw Hans, I think, mentioned in the chat, the dyspnea pyramid as the organizing schema for thinking about shortness of breath. And to tell you the truth, that like specific descriptor of can't take a deep breath maybe enriches some of those possibilities, right? Pleural effusion, a distended acidic abdomen, maybe, I don't know, musculoskeletal weakness or some chest wall abnormality that causes pain, or pleurisy, or a pleural abnormality that causes discomfort with deep inspiration. So I might be thinking of some of those possibilities a little bit more closely as I listen to the story and do the exam. But honestly, I don't, I'd be open to every cardiac, pulmonary, and blood cause of dyspnea still at this point, and certainly with the tachycardia. So I think the whole world is out there. I'm at the edge of my seat to actually hear the answer to the question. All right, sir, tell me the story. Tell me a little bit about what's been going on.
Yeah, so for the second aliquot, I'll talk about the HPI, the review of systems, and then other relevant past histories. And I think we were sort of thinking the same thing, like it felt like the differential was wide open. So we go down to the ED, and we see this 79-year-old gentleman with a full head of white hair. He's got this New York accent. He's from the Bronx, and he's overall well appearing, and so we start talking to him, and he says, for the past month he feels like he can't take a deep breath, and that's basically all he kind of gives us. And so we ask him, is it worse with activity? Doesn't seem to change doesn't get worse or better with activity. He notices it pretty much all the time. But he decided to present that day, or on the 24th, because he felt like he just felt more anxious about his symptoms, but they hadn't actually worsened. He tried NyQuil one night, which didn't really seem to change anything. And notably, he actually walked to the VA emergency department from a nearby bus stop. And he denies any recent trips or long plane rides. And that's essentially the HPI in a nutshell. Moving to the review of systems. So in terms of pertinent positives, he does report that there's no easy way to say this besides he describes his stools as being Tootsie Rolls for the past 2 months. And he feels like he has to strain more when defecating. He's also noticed if he had like a rectal polypectomy about a year prior, and he had lost 15 to 20 pounds after that. But he has since regained all that weight. And he does feel like his abdomen is more swollen as well. In terms of pertinent negatives, denies a cough, no fevers, no chills, no sick contacts. He feels like his symptoms haven't changed with the change in temperature, and no blood in his bowel movements, no pain or difficulty with urination, no leg swelling, no orthopnea, no PND, and that's about it for the review of systems. Moving into his past medical and surgical histories, he has a history of bladder cancer that was diagnosed in 2019. Um, but he's had surveillance cystoscopies, and I think his most recent was about a year ago. That was normal. He had a large rectal villus adenoma that required resection with general surgery, also about a year ago, that required subsequent ileostomy and takedown. Um, and then he also had like a right hip surgery more than a year ago. Other things in his past medical history, his history of insomnia, for which he takes trazodone every night, and depression, for which he takes paroxetine, and he's been on that for about 30 years. And in regards to his family history, he says his father died of emphysema, his father was a heavy smoker, and he says his mother died of old age, and wasn't really sure what other conditions she had. And in regards to his social history, he was born in the Bronx, moved to Denver a few years ago. He's estranged from his family, and he used to work in HVAC in New York City. He's now retired, never used tobacco and no alcohol use in the past 30 years, and no other drug use. And I'll go ahead and stop there, but happy to answer any questions.
Thanks, Hirsch. And Happy New Year, everyone. Zaven, I'll just sort of add some great thoughts onto your great initial discussion about what the additional history tells us, and then turn to you to see if you think anything in the past medical, family, social, et cetera, kind of enriches things. Throughout Zavin's kind of initial discussion, I was really thinking about, what's a succinct word for can't take a deep breath, other than dyspnea? And what really struck me is like, this is even when people say that, they mean even at rest, right? They can't get the air in. And I'm struck by that syndrome being present in this gentleman, that is constantly feeling that way. And that walk from the bus stop to the emergency department was still feasible for him, though. It's just a very interesting syndrome of feeling, I'm going to say, short of breath or dyspneic, but still being able to kind of go about your life. I think it makes it really sort of interesting for, again, some of those causes that are both neuromuscular as well as sort of lung, pleural, parenchymal, and then perhaps certain cardiac issues also. So the fact that it's been present a month, but not getting worse, to me is not really reassuring. It was a sort of very clear onset, it seems like, in the timeline, and really not getting better. I think prioritizes just a lot of the diagnoses that have come up in the chat already about pretty scary things that can cause shortness of breath, as well as this concurrent tachycardia. The change in stool caliber over the past couple months, particularly in the context of having had a villus adenoma of the rectum removed, certainly does make us worry about what's happening in terms of rectal masses or pathology that are changing actually the ability of stool to get out. Other things to think about when someone talks about stool caliber change also is, are there dietary changes? Are there other issues just in terms of functional challenges with being able to kind of have regular bowel movements? But in this gentleman, it just sort of puts a pit in my brain wondering about what is the status actually of that prior kind of rectal lesion that was removed. Because the other interesting set of symptoms that Hirsch has given us is a pattern of weight loss and then regain. And we've talked in a lot of episodes about how to approach weight gain systematically, how to approach weight loss, but how do you approach big weight loss and then regaining it all back again? Sure, it can in some people be, right, sudden change in lifestyle diet that then they revert back to what they were doing before. But in a 79-year-old gentleman, I worry about pathologic processes driving both the weight loss as well as the regain. In this particular case, having an inflammatory cause of weight loss, we're hearing about some history of malignancy in the background as being that. But why regaining the weight again? That makes me worry a bit about sort of volume status, particularly with that abdominal distension syndrome. And Zaven mentioned before, right? If this gentleman happens to have, new significant ascites, the lungs can be totally fine, but that can be actually a restrictive reason for someone to be dyspneic and not take a big deep breath. In fact, I feel for a lot of patients with advanced cirrhosis who are admitted to the hospital and have significant ascites, dyspnea is often one of the chief concerns there. And so for this gentleman who has lost weight for potential inflammatory malignant reasons and regained it, I think our volume status exam looking for ascites, both intra and extravascular volume, is going to be important. Because I think that gain, loss, and then regain makes me worried about two different processes happening with that. What do you think in terms of his other medical issues, other than what I've sort of touched on with the malignancy history? Does anything else come to your mind?
I'm gonna mute for a sec. Thanks, Steph. Yeah, I think that was a great thought about the weight loss and regain. For some reason, my immediate assumption with that history was it was with a rectal, what? It was a rectal
Villus adenoma.
There was a villus adenoma that required the resection ileostomy, but wasn't there a rectal pathology, Hirsch, too, that you mentioned?
No, sorry, it was just that one large rectal polyp.
Oh, I see. A rectal polyp.
Yeah,
Okay.
so it was like a villus adenomatous
I
polyp.
see. Got it. For some reason, I for some reason thought of, like, I guess more distal rectal anal sort of pathology and potentially related pain, and it just made me. I just have a bit of an availability bias of having having had some patients recently who have either constipation or other sort of perianal disease that is so uncomfortable that it makes them want to not eat. And was kind of struck by the degree of that. But anyway, yeah, I think certainly he has sort of intestinal, intra-abdominal pathology in the past. He could have more or recurrence or a complication of old processes, and now having, I'm very much interested in seeing how big and how tense his abdomen is, and whether it's tender, and whether his sort of actual objective ability to inhale, move air, move his diaphragms down on examination seems okay or not. I also just want to kind of add to what I was saying before, which, that sort of that feeling of breathlessness for related to anxiety. We kind of, as you alluded to, we got the other potential feature of that, which is maybe it doesn't get better with exertion, but it doesn't get worse either. And I do want to make it clear that actually, that anxiety itself can be from a different organic medical process, right? So you could be feeling sick in some other way, neurologic or otherwise, and the only diagnosis isn't just an anxiety disorder. And I've definitely seen some patients like that too, who present with that kind of breathlessness either as a primary symptom or as a secondary symptom, but there's another underlying sort of illness that is sort of driving everything. So yeah, don't have much more to build, and I'm excited to see what like. Are we still good? Yeah. Can I also just add and comment, Hirsch, how sort of efficiently and clearly you presented this gentleman's history. I feel like everybody listening just like has a really great sense of who he is, both medically, but also just as a person. I can almost like picture this guy with just a few words that you mentioned, just about his general appearance, about his vibe, his old profession, where I feel like you both painted a very clear picture of what his physiologic journey of health has been, as well as just who he is, and sort of have humanized him. So thank you for that.
Yeah,
Can I make one quick tidbit? And that is, I'll say I have this fact to point out based on a case that I've missed, and then another case I know Alec Rezai, who's one of our dear CPS members, has made a diagnosis in real life, that if this gentleman's surveillance cystoscopy had happened a week or so before his syndrome started, actually thinking about the simple kind of complications that can happen with that procedure of little bladder rupture and then urine going into spaces where it shouldn't be, causing urine in the peritoneal cavity, urine ascites, or urine even as a pleural effusion. So the cystoscopy a year ago, I think we're out of the woods, but I'll say because of a case that I missed, and then hearing about one that Alec made, just being sensitive to how routine procedures that internal medicine that we may not do can have complications that lead to syndromes with which we're very familiar, but fortunately doesn't seem to be the case here. Would love to see what he looks like, Hirsch.
Yeah, absolutely. No, and I think that was a great discussion. I mean, those are the things that we were also worried about initially was, I think, like concern for malignancy was like sort of the thing I was most concerned about. And then the tachycardia felt particularly ominous. And so for this third aliquot, I'll go into the objective data. So vitals wise, he was afebrile, and these are all his admission vitals. Afebrile, heart rate of 122, blood pressure was 147/79, rest rate of 20. And in the sign out from the ED, it sounded like this patient had desatted to an oxygen saturation of around 80% or somewhere in the mid 80s with walking into the ED, and thus required 2 liters nasal cannula. However, when we went down to see him, he had the nasal cannula in, but there was no oxygen running, and he was satting in like the mid 90s. And then I'll pull up his admission EKG as well.
Can I just say, Hirsch, I love that like reality check with oxygen and nasal cannula. Is it in the nose? Is it on or not? Really helpful information. We still need to believe the emergency department, right? That he was
Yeah,
hypoxic after
of course.
walking.
Yeah.
Great to know that he's looking pretty good sitting there when you guys see him.
And so this is his EKG, and I'll give you guys a couple seconds to take a look at it.
Yeah, everybody try to work through this on your own, and maybe in a few seconds when I say go, please share any thoughts on the EKG. All right, what are people seeing?
Want to keep it up?
Yeah, Hirsch, do you mind just
Oh,
keeping it
yeah.
up?
Can you guys see that? Okay.
Yeah, perfect. Nice, Larry. Yeah. There's a little bit of prominent LV voltage in V2, V5 kind of added together, probably come close to the kind of normal cutoff for an older person. And then if you look at lead 2, everybody, you can kind of see that the P wave is a little widened and bifid. So some signs of elevated left-sided intracardiac pressures that have been sustained for long enough to cause structural change and electrical changes. And then what's the rhythm, just to make sure we're all on the same pace? Because to me, that's a really important kind of dichotomy. Anytime where we have a fast or slow heart rate is what rhythm are we in? Thanks, He. Yeah. Sinus tach and yeah, and everything else, there's a little bit of a sort of T-wave flattening, ST depressions maybe in the inferior leads, but and in the apical leads V5, V6, but sort of on the spectrum of what you might see as a repolarization abnormality from LVH. So it would be helpful to have a more of a baseline, but otherwise I think we've kind of mentioned the main findings on the EKG. Thanks, Harsh.
All right. Yeah. And I agree. Those are pretty much the same findings I had as well. And so for his admission exam, or I guess the exam, or my exam when I went down to go see him, so he's well appearing. He was initially laying flat in bed when no apparent distress. In terms of his HENT exam, he had poor dentition with some dental caries. Cardiac exam, no murmurs, rubs, or gallops, regular rhythm, or I guess like sinus tach. And then possible JVD up to the mid neck. My JVD exam is not great. I pulled him up to 40 degrees, and I think I was like, maybe I see some JVD. But his lungs sounded clear. Didn't hear any crackles or anything in the bases, no clubbing. His abdomen was soft and non-tender in all 4 quadrants. Didn't appreciate like a fluid wave. Not that I really know how to do a fluid wave well, but didn't seem like particularly distended. He had no peripheral edema, no focal neurologic deficit, and overall he was cracking jokes with us. He was asking if we we asked him like any other questions for us, and he asked us, do you have the lottery numbers for tonight? So overall he was doing well, and no other rashes or bruising that we could see.
Yeah, great. I feel like I've heard that joke before. I don't know if that's like a one-liner in some of our patients. It's a good veteran
classic
joke, huh?
VA. Yeah.
But again, just painting a great picture, Hirsch, of like this guy's, not feeling well, but mentally with it, right? Like spirits are okay. Just really helpful to see how he's doing clinically. I think I'd just kind of succinctly say what we've found with the exam is for this gentleman with subacute dyspnea. He has exertional hypoxemia, sinus tachycardia, and elevated, at least right-sided filling pressures. But my guess is once we get additional data, including a chest X-ray, et cetera, what we're really starting to get a picture of is potential increased filling pressures on both sides of the heart and helping us perhaps sort of start filling in the cardiopulmonary sort of category for dyspnea. Can he be in new heart failure without signs of profound volume overload everywhere else? Yes. I think you have waxed eloquently before, Zaven, in one of these sessions about just the powers of the lymphatic system and how even patients with kind of new decompensated heart failure can have really high filling pressures and not actually develop significant edema, significant ascites for a long time. And that's why up to 1 in 5 patients with heart failure can have a pretty normal looking chest X-ray also. So I think even in the absence of just profound total body volume overload, again, I'm worried about processes that make intracardiac filling pressures high also. The fact that he feels fine lying flat is a piece I'm trying to reconcile in my mind, because that really should make him more dysmic, and you gave that as a pertinent negative upfront also, Hirsch. Does it lower the kind of post-test probability of that maneuver that much for me? Not a ton right now based on some of the other data, because I also wonder if we let him lie there for 10 minutes instead of 30 seconds or a minute, would he start to get a little comfortable with that ability to not take a deep breath, kind of come back a bit? So I think it's a pertinent negative that you mentioned also in the history, but I'm still sort of zoning in on that category of kind of cardiopulmonary and increased filling pressures now. Do you have thoughts to add, kind of based on just the exam assessment?
No, I'd be really, there's a bit of this disconnect between some of the history, what we got, this thing we heard from the ED. So to your point, Steph, I kind of want to take a walk with this guy and just see what his breathing pattern and his symptoms are just in the flesh when he's exerting. But, I think the tachycardia is just still very objective and very much there, right? And it's almost, I kind of want to be thinking about it in parallel, where especially in a person who's just otherwise feeling fine-ish, looking fine-ish, there's not clearly some inflammatory syndrome based on the history or the exams. I think this is the situation. And with this weird respiratory syndrome that we haven't further elucidated, this is the patient that I get tingly about pulmonary embolism. And it also fits with the slightly elevated right-sided filling pressures we're seeing on exam, but the clear lungs on exam. So I'd actually, can we just go back to the ECG for 1 second, Hirsch? And
Yeah,
this is normal to kind of reassess data in an iterative way when some of your hypotheses sort of shift around and you kind of maybe didn't look closely enough at some of the potentially supporting findings as you would have otherwise. So what I'm looking for here, obviously there's the sinus tachycardia, but some of the other findings of elevated right-sided filling pressures you can see on an EKG is a rightward axis, or an axis that's shifting rightward from baseline. Right atrial enlargement in addition to left, which we're not seeing here. T-wave inversions representing RV strain that you would see in early precordial leads, V1 through V3, that we're not seeing. And especially if those T wave inversions are paired with inferior T wave inversions, that's one of the more specific findings of PE on an EKG. And then just other kind of signs of elevated right-sided pressures. You can get a right bundle branch block or an incomplete right bundle, seeing a late kind of positive force in V1, a prominent S wave, late negative force in 1, neither of which we're seeing. Q waves, T wave inversions in lead 3. We're seeing none of that signature, which, if present, would definitely have been signal to me, but when absent, doesn't lower my post-test probability. Thanks for showing that again, Hirsch.
Absolutely. Should I move on to the next aliquot?
Please.
Okay. All right. But I think sort of like what we're hitting on here is, I think, exactly what we were thinking about too. Like the sort of fork in the road kind of felt like, do we chase like malignancy PE kind of pathway versus is this something like more cardiac in nature? And so I'll for this aliquot, I'll give some labs and imaging. So his CBC was largely normal, with a white count of 8.8, hemoglobin of 14.4, and platelets of 281. And his CMP was also normal, sodium of 142, potassium of 4.2, chloride of 107, bicarb of 22, BUN of 13, serum creatinine of 1.04. And looking back at his chart from about a year ago, it seems like that's roughly his baseline glucose of 106, and then his total protein, ALT, AST, all were within normal limits. Additionally, his ESR was 14, CRP was 5.72, both for which were normal. His tropes were 23 on arrival and downtrended to 21. Both of also were normal. His pro-BNP was elevated at 1,853. His D-dimer was 480, which was normal for his age. And then otherwise, his MRSA NAIRS was negative. Flu-vid, so that's a test for flu and COVID, were negative. And his urine analysis and urine tox were also normal/negative. So that's it for the labs. And I'll go ahead and show you his admission X-ray as well. That's the lateral view, and this is the frontal view. Can you guys see this okay? And let me know if you want me to make it bigger.
Okay, same exercise, everybody.
Sorry, let me just let me exit out this EKG.
Thanks.
Okay.
When we have the X-rays, just take a look, see what your best kind of interpretation is, and then when I say go, share what you're seeing in the chat. That way all of us can have some practice. Oh, no. All right, let's hear it. There had to be a CT. In fact, I was gonna beg
I
for
wanted
it.
the
Yes.
CT before. Yeah,
It
I was
was-
like, we're gonna
we
get
need-
X-ray and a
We
CT.
need
This
the
is
CT, but what are people seeing on the X-ray? Yasmin, bye Ruby. Perihilar nodular lesions. Yeah, Yasmin, I think what I'm seeing is a little bit of sort of prominence of the perihilar kind of bronchovasculature, and some of the ones, and most of those look like lines that are thicker than they should be. But other ones look like circles, and that's when sort of a blood vessel is on end, kind of going anteroposteriorly, it's going to show up as a circle as opposed to a line. So I think that is that what you're seeing maybe? And then as far as the air spaces, yeah, it's a bit subjective here, where I feel like a lot of people would call this within kind of normal sort of spectrum, especially because the breath isn't a very big breath, and things in general just tend to look denser when that's the case. But I can see some what could be some patchy airspace opacities behind the heart, especially. Um, and then the pleural angles aren't perfectly sharp, are they? Small pleural effusion. So overall, oh, hey, Austin. Um, um, Overall, what do you think, Steph? Would you kind of say that there's a bit of a pattern of potential cardiac, like mild pulmonary edema?
Yeah, I think so. I think having the lateral is so helpful. I didn't learn how to read a lateral till I was kind of a couple years into my career, I will say. So for this case in particular, a few things that I think are pertinent is when we're particularly worried about pulmonary edema. We don't see the fissures at all on the lateral, and that's normal. At most, you should see it pencil thin, but if someone has a fair amount of interstitial fluid or fibrosis, et cetera, you can see them. But just as the other thing to take note is, I agree with Zaman that there might be tiny effusions there. We'll see what the CT shows. Just the same way the angles should be crisp on a frontal X-ray, they should be crisp on a lateral X-ray. And you guys can see, particularly for I think that's the right-sided diaphragm, it's it's a little bit curvy. And a quick fact is that you can see a pleural effusion sooner on a lateral X-ray than a frontal. It takes over 200 cc's of fluid to start see blunting on the frontal view, whereas it's like less than 100 on a lateral. So there might be a sign of some little teeny effusions there. I agree with some of the increased interstitial markings. So
fits with the EKG, fits with the BNP.
yeah.
And
I guess it's worth saying, does it make us less worried now about PE with all the data we have? We've got, I can't remember, you said an age-appropriate D-dimer. We have this X-ray. I'll say I'm less worried. Am I putting myself in the emergency department of your admitting team's shoes? Am I less worried enough not to look for it? I'd be talking about it. I'd be seeing what everyone on the team thinks, because I do think this is sort of heading in a direction where we thought in terms of other reasons for high filling pressures. But
I think the one thing that's weird to me is that, I think my suspicion of PE wasn't quite so high for the D-dimer. Like the D-dimer kind of probably puts me below the testing threshold in most of the time. But here's the thing. If you make PE less likely here, you have to make something else more likely,
yeah.
for the tachycardia. So let's say parallel universe, the heart rate's 90. Okay, what I would say, 90% of patients like that, presenting like this, everything we have so far, except the heart rate is 90, is just plain vanilla heart failure. The EF might be 30, the EF might be 60, but this is heart failure. They get diuretics, they feel better, like they get whatever GDMT it's indicated. That's the diagnosis. They feel better with the treatment. That's it. The heart rate of 120 is creepy here. It doesn't fit with the degree of dysfunction that we're seeing elsewhere, the degree and severity of symptoms, nothing else, right? So if it's not a PE driving that, we have to find something else that is, right? And it may be, and we don't have it yet. So I think the height, if I had to pick a single biggest test to look for the reason, it would be an echo to see like just how low is the EF if it's low. Is actually the sort of kind of bulbous shape of the heart that we're seeing, like, is it the heart or is it the pericardial fluid, right? And pressure. Which I don't know, it's a bit of a roundish heart. There's a bit of a sail sign that's probably the left atrium accounting for that kind of left upper kind of border of the heart that should be concave but is now convex. But I just wouldn't be surprised to find something striking on the echo to explain that heart rate, because that's a lot of norepinephrine. The other one possibility is, you can have sort of high right atrial foci of ectopic atrial tachycardia that looks, almost or just like sinus, but it's not. And so it's an inappropriate tachycardia, and in fact, maybe the cause of the heart failure syndrome that we're seeing otherwise. So I'd kind of, we have to again turn almost every stone to explain what is probably sinus tachycardia, but keep in mind that this could be still an ATAC, a tachyarrhythmia that is sort of its own thing and potentially a driver of the rest of the syndrome.
So we want the CT.
We want the CT, and I want an echo.
Ask and you shall receive. Well, so actually the echo is interesting. So because, so for those of you who don't know, when you're at a VA, it's a federal building, or it's a federal, hospital. So, people get days off on federal holidays. And so we knew we weren't going to be able to get an echo until at least the 26th. Because at this point he's coming on the 24th evening, the 25th, no way he's getting an echo. And so this is something that's running in the back of our mind as well. And I agree, like, the D-dimer was reassuring, but given his like sort of malignancy history, the tachycardia, the sort of respiratory symptoms, we didn't feel comfortable just like resting on the D-dimer, even though, it has pretty great test characteristics when it's negative. So we went ahead and got the CT, which I will show right now. And I'll just play screen recording.
And I think, Hirsch, I'll just say that, I would totally support that, in part because, yeah, you haven't totally ruled out a PE, but in part because when it comes to sort of reasons why you might suspect a pulmonary embolism, a CT-PE is so much more than just ruling out or in a PE, right? It's sort of imaging the rest of the pulmonary parenchyma, the pleura, the parts of the heart, honestly, the upper abdomen, just so many places where other kind of pathology causing dyspnea, tachycardia, like whatever it was that was the entry point to considering a PE could be. Can you play that one more time? And sorry,
Yeah.
distracted everybody while they were looking.
I'll tell you what I saw and see what you guys think. The lung parenchyma looks really good. We were wondering about the interstitial opacities, but I don't see, increased interstitial markings. I don't see ground glass, all the findings of extremely nonspecific when there's cardiogenic pulmonary edema, but the lungs parenchyma look great. I don't think I saw a PE in anywhere trunk out to the at least the segmental level. Feel free to shout out if you feel you saw something different. And then we're confirmed in our chest X-ray readings of pretty small effusions, but easy to see on both sides. I didn't look closely at kind of lymph nodes, so thanks for bringing that up, guys. And what else did you see? / do you agree? Maybe some large lymph nodes and bronchioles in the subsegments.
There's a little bit of bronchial wall thickening, maybe. The other thing that I was just looking for is like it's a very good PE angiogram. The right ventricle pulmonary arteries are super well opacified. It's well timed. It's a high sensitivity study. The pulmonary artery, if you kind of scroll up a little bit, or comparing to the ascending aorta, isn't enlarged. So again, not only is there not a PE, but there's also not probably at least advanced pulmonary hypertension that can also just present with, right, sort of like a otherwise normal looking CT. There's not a big pericardial effusion. There's very slight left pleural effusion. The airways on X-ray, it looked like the trachea might have been a little bit narrowed, but it's totally patent and fine. Nothing sort of obstructing that I saw. But again, it's hard without sort of being able to scroll and look for what I'm looking for. The esophagus is a little bit sort of patulous, but not too bad, and wouldn't be related to any of this. Honestly, pretty normal CT from what I've been able to see so far. But tell us, Hirsch, if we missed something.
Yeah, so basically didn't miss anything. The official read said that the pulmonary artery is normal and no filling defects are seen. There's some hepatic steatosis. And then the other thing I was curious about was like, you know, like sometimes you can see some evidence of atherosclerosis on CT, but it's the read says no significant atherosclerosis in the thoracic aorta, and yeah, I think that was the only comment on that. Oh, actually, then moderate coronary artery calcifications. But that was basically, yeah. I don't think there's anything more to say on the CT really from the official read.
Let's pause for a sec, actually. Hirsch, how many more aliquots do you have for us?
I have one more aliquot, and in the sixth aliquot, we'll have the diagnosis.
Okay. And then
insofar as we know it.
Sure. And then did you kind of mention the echo, or is that like going to be still upcoming?
It's Christmas Eve at the VA.
Oh, that's right.
Exactly. Yeah.
Well, okay. So, all right. So we have an older, generally healthy, well-spirited man coming in with a month of kind of mildly bothersome dyspnea at rest equal to with exertion, with normal hemoglobin, bicarb, exam, save for maybe mild elevated JVP, EKG, save for maybe some LVH, left atrial enlargement, and chest CT not showing a kind of significant pulmonary edema, PE, other parenchymal pleural disease, who is tacking away at 120.
Has a BNP of 1,000.
And has a BNP of 1,000. We're missing an echo. By the way, just like grossly, the LV wasn't super dilated. The RV wasn't bigger than the LV on the CT scan. And again, there was no pericardial effusion on the CT scan. So what's our differential? Here, let's take 30 seconds. Everybody commit to your top 3 diagnoses. And but don't type in a chat yet, please, so that everyone has a chance. And then we can kind of share. Okay. Let's hear it. It's a great question, Mark, by the way.
Sorry, what was the question in the chat? I'm having a hard time managing. Oh,
Tachycardia.
Okay. Yeah. So when I saw him in the ED, he was down to like the 110s, but he basically didn't leave the 110s for at least the first, 6 hours or like 4 to 6 hours that I saw him. All right. Should I go ahead and
well let's I'm just if somebody wants to share kind of their kind of top suspicions now, and Steph, I don't know if you want to riff at all.
Yeah, I think being very pragmatic about what I would do in real life is so far the imaging, everything is somewhat reassuring. I would actually work sinus tach and the subacute dyspnea as separate problems, realizing they'd overlap. Make sure I'm not missing another cause of sinus tach, like withdrawal syndrome. You mentioned the negative talks, but I'd re-go about history. I'd get a TSH to say, oh gosh, is the Tootsie Roll stools hyperdefecation, and was the weight loss thyrotoxicosis, right? I would just kind of work sinus tach to make sure some other cause, because that really, it's a scary vital sign. Doesn't fit with how this guy looks and how his imaging looks. So very pragmatically, I'd separate the two problems, work to death the sinus tach differential diagnosis.
To life.
Probably to like work to life. And realistically, like there's some excess volume in there. We have I'd start diuresing him. Like that would be sort of my approach. So I'd say maybe there's some heart failure here. I would guess preserved DF. Oof, but the sinus tachycardia, give me a TSH, give me a little more history. That's just what I would do in real life on Christmas Eve with you guys.
I love it. I'd keep him on telly and see if there's any periods where he goes 120, 65, 117, 70, because that would just confirm sort of an arrhythmic source, and specifically ATAC in this case because they have the EKG looked. And then the other thing, I'd go back and talk to him and just be like, hey, how you been, like, just life-wise? What's going on? And to try to get a sense of maybe if there is some stressor, something that is different, new, scary, anxiogenic, because people can, people can put on a brave face sometimes, but in fact, there's actually something very emotionally difficult going on. But yeah, I think those are great practical next steps.
And Rich, I love your just whole thought of like high output heart failure syndromes, right? Which can be driven by a multitude of things, thiamine deficiency, thyrotoxicosis, et cetera. So yeah, I think those will be important things to think about as we kind of run our basic list for sinus tach. Excited to hear what you got.
Yeah. Yeah, so I think it sounds like we're really honing on the sinus tach, and that's exactly what we were also most concerned about. Um, and um, and I think like heart failure was sort of rising to the top of the differential, but like, the etiology was sort of confusing, and not being able to get a TTE definitely felt like a hindrance. But so, I left the hospital that night, and came in the next morning, and I'm sort of taking you guys along chronologically with me here. And I took a look at his tele that morning, and he was sort of, around like the 110s all night, all except for that. Well, then we actually gave him, I before I left the hospital, I spot dosed him with Lasix 20. And then it seems like after that, his heart rate kind of came down like the 90s, 100s, but still above 100. He had like fairly frequent PVCs, but otherwise was never really dropped below 90, even when he was sleeping. So then when I was pre-rounding that morning, I was like, all right, I think this guy's got like a sick heart. That's like the PVCs and the fact that he responded to some Lasix makes me worry that this is localizing to his heart and not so much like a systemic process. So I did a little bedside POCUS because, it's Christmas, can't get a TTE. So I will pull up quick video of my POCUS. You'll see my reflection in there, which is a little embarrassing. But so I did all four views that I could, but I was only able to like, use my phone to record the iPad for one of the views, which is the 4-chamber. And so I'll play this video for you. But in addition to this video, I also saw that he had, I thought his IJ, so I pulled him up to like 40 degrees. I thought his IJ was dilated up to his mid neck and didn't really collapse with respiration, but his IVC was collapsible and, on gross estimation, like less than 2 centimeters at 1 centimeter away from, or like from his hepatic vein. And so I'll play this video real quick.
Hirsch, I'd go with your IJ over the IVC. Just a quick sort of POCUS related aside.
Okay.
I think the data is better there.
Oh, you can. Oh, shoot. Sorry, I'm playing the. Let me share my screen. Thank you for Maddie for keeping me in check.
There you
Can
are,
you
Christmas
guys see it?
Day.
Yeah.
Wow.
I'll play that again.
Wow.
Great.
And let me know if you want me to play it one more time.
Hirsch, actually, since you have the cursor, do you mind just sort of point out to everybody who may not be, as familiar with kind of interpreting these, sort of what you're saying, what's what and what you're seeing that people are saying wow about?
Yeah, so this is the LV, I'm pretty sure, right? And this is the RV. This is the left atrium right here, and then the right atrium, I believe, is right up there. And I think the notable findings for me here that the LV looks like grossly distended. And then the overall squeeze, it's to me, it seems like there's some just like hypokinesis. It just doesn't seem like the walls are moving as well, and I don't see them thickening as much as I would expect. But I'm still learning how to do POCUS, so don't trust my read on that yet.
No, that EF looks very low. I mean, that especially the apex, that we're not seeing the lateral wall very super well, but like the apex is just sitting there. And and the EF just sort of eyeballs low enough that it could be that the tachycardia, again, wasn't driven by sympathetic tone of the degree of sort of breathlessness with pulmonary edema, but like compensating for a low stroke volume, you know? Yeah, I mean, I think that's a great sense. I love the way you put it, that you just sort of like put everything together and you're like, this guy has a sick heart. You know, that's sort of the center where everything is sort of triangulating, right? And to try to expend your cognitive and time energy in that direction. So take us home. What do you want to do here? Sort of tell us what happened, or any other things you want us to kind of comment on?
Yeah, just one quick thing I forgot to mention was that his TSH and T4 were normal. Just kind of circling back to that. So yeah, the final aliquot is the TTE, which he got on the 26th. I mean, you guys want to take a guess as to what his EF was?
15.
10%.
Yeah, so his EF was 30%, but with global hypokinesis. The RV was normal in size and function, mild MR regurg, or sorry, mild mitral regurg. There was a small trace pericardial effusion, and those were the significant findings from the TTE. So as far as we were concerned, like the final diagnosis was new onset HFrEF, and so we consulted cardiology. And then sort of the question was like, well, then what's the etiology here? As HIV was negative, thyroid studies were normal, iron panel was normal. Cardiology recommended an outpatient nuclear stress test. And when cardiology went to go see him, they were concerned for a possible viral etiology, because it sounds like this patient, and this is something that I didn't pick up on history, had a flu-like illness 2 months prior. And so I guess like one of my questions is the lack of like a regional wall motion abnormality, does that make you more concerned for a possible like viral process, or does that mean that it's less likely that one of the coronary territories is down? But then we started him on GDMT, and he ultimately left with his heart rate in the 80s, and feeling significantly better from a respiratory standpoint.
Truthfully, I'm not a cardiologist. I'm surprised he didn't get an inpatient cath. Or just kind of significant 3-vessel disease just causing like global balance to ischemia, right? But maybe they were relying on some of the kind of non-invasive parameters from the CT, the fact that troponins were not elevated at all on admission, and no regional wall motion abnormalities. But yeah, the concept of balanced ischemia is that everything looks the same because it is, because it's everywhere and the perfusion is just down in all regions.
Yeah, I think I definitely wouldn't, like, probably half of us had a flu-like illness 2 months ago, and I think that just doesn't move the differential too much for me. It's possible, right? But I think you can't not work up everything else sort of as usual. But Hirsch, thank you so much for presenting this amazing case, and I think sparking really fun kind of practice exercise. Great case, great presentation, and thanks for everybody participating and sharing your thoughts in the chat. And otherwise, let's close with Kashariar, if you want to summarize any salient teaching points.
So just to highlight a few of the points that I found really interesting for myself was how we generally started approaching the patient. First is how we just frame the entire initial presentation and how we see it. I really enjoyed the discussion around how can't take a deep breath can be translated to different causes, that some of them actually showed themselves, like MSK weakness, pleural effusion, abdominal distension were the things that we need to think about while we were approaching a dyspnea that presented as can't take a deep breath. And within the dyspnea pyramid, I really enjoyed the diagnosis of exclusion, how anxiety can be itself a cause of dyspnea, but it's a diagnosis of exclusion, because a lot of times patients are just anxious because we can't figure out why they're dyspneic. And we have to always remember that it may not be just an anxiety disorder. Many organic processes can lead to anxiety disorders that can present as dyspnea. Finally, just to review how we brought all of these findings together, a heart failure picture could have presented like this in many ways. A key point here was how the tachycardia wasn't fitting the rest of the picture. The EKG findings and X-ray findings were also supportive of such presentation. And some of us may have the question of why is the patient looking so relatively well compared to the syndrome they're presenting with. And I just want to point out how awesome the lymphatic system can be, that many patients who present with a new onset heart failure can present without edema and a normal chest X-ray despite being volume overloaded. Thank you so much for the great discussion, and thank you, Hirsch, for the great case. I learned a lot.
Stellar work, Hirsch. Congrats, everyone, on working through this. And what a great way to start 2025. Here's to many more great cases and great medicine this year. Appreciate spending some time with you guys. Have a great rest of the day.
Thank you, everyone. Happy New Year, and thanks for letting me present this case.
Bye, guys.
Thanks again. Happy New Year.